All right, guys. So this last set of slides, I think we can get through pretty quickly here. This is a lot of just kind of bonus stuff. So I'll tell you what you need to know for the test here pretty easily. But just to go through some med safety stuff is sort of, I think, something that is important and gets glossed over a lot. In case you're wondering where to find certain items, like if you have a patient who has a bunch of meds they need to take down a G-tube, and you want to know about like a do not crush list, ISMP, Institute for Safe Medication Practices, is a resource for that. They also talk about black box warnings, FDA alerts, abbreviation stuff. NIOSH, you guys probably maybe heard of NIOSH before, but NIOSH has a list of medications they consider to be hazardous. So a lot of them are like hormonal related things, but there's lots of stuff on there. So like anti-rejection meds for transplant would be on there, and then chemotherapy and stuff like that. If we're wondering if something has specific occupational hazards, like if you're working with medications and you're handling them for some reason, and you're like, I'm pregnant and I want to make sure that this isn't going to affect anything, to do with the developing baby, well, that's a good place to check that. Or your patient would be maybe more of a likely situation, I would say. Not pregnant, but just handling the meds, right? IHI, Institute for Healthcare Improvement, has a list of what we call high alert medications. They're considered the dangerous things. We're going to talk a little bit about how we prevent some of these risks in the hospital setting, but we'll get to that in a second. Oh, this is a great one. So for your patients out there, I get this question all the time about where do I dispose medications, and Hennepin County has if you don't live in Hennepin County, I don't know if Ramsey has a similar thing. But anyway, most people in the metro area probably can access one of these sites. And if you go to that website, it will show you a number of locations where you can drop off medications. So acceptable items, not accepted, guidelines. You can actually put controlled substances in these things. What they are, they're usually at police stations or city hall type buildings. These big green like mailbox looking things. You can just go and put your medications in them. They get disposed of properly that way. So one of the big issues with accepting back medications, specifically controlled substances, is you get DEA regulation involved. So by putting these things in police offices, or police stations, they have gone around that so that at least there's some regulatory involvement that way, and the DEA can be involved with taking back these medications. Occasionally you see community events too with take-back events, like they're usually at fire stations or police stations for those reasons. So if you're ever wondering why people have to bring their meds to like a public place, that's because of that reason. But usually there has to be some sort of oversight involved as well from some sort of a healthcare official too. Anyway, you get a patient, I've got all these extra meds, I've got tons of Percocets from all my surgeries, what do? This is your answer right here. Do not sell that. Yeah, that's wrong. I'm going to put a test question just for this. All right. So an adverse drug event, we've talked about these all year, some sort of injury resulting from taking medication. So how do we prevent these? And there's plenty of things that are non-preventable. So let's say somebody gets dry mouth from antidepressant. Well, that's going to happen. Somebody gets anaphylaxis with penicillin. It's their first dose ever. You can't avoid that. You can mitigate the effects of it, but you can't avoid that. The ones we want to focus on really from a health system, healthcare perspective are the preventable ones. So I'm going to skip through a lot of this, but basically ADEs cost a lot of money. There's been a lot of evidence and studies looked out there that say that there's ADEs that occur all over the place. They're a huge chunk of healthcare expenditures. They cause increased length of hospital stay. They have increased visits to our emergency departments. So there's a number of different studies out there that show that. Up to 1 in 30%, or up to 30% of hospitalized patients will have some sort of adverse drug event during their hospital stay. That could be anything from a near miss to like an actual, like we gave you the wrong medication and you died because of it. That'd be, of course, very rare, but like 3 out of 1,000. Long-term disability, quite rare as well. But giving somebody the wrong med or a mix-up is more common than we like to think. We have a reporting system, and if it's a severe enough thing, our hospital will have a critical event review where it gets everybody involved. You talk about the fail-safes that might have gone wrong during the process, and maybe talk about mitigation strategies for how to make sure it doesn't happen again. Financial burden, of course, length of stay, anywhere from $1,900 to $5,900 is what's estimated per adverse drug event with different studies. So depending on the hospital, is there something going on? Sorry, but yeah.
Her snack is stuck in the wrapper.
Okay. Maybe wait till 5:30 to have your snack. I don't know. Just say it. All right. Give me like 20 more minutes of your time and you never have to see me again, I promise. All right. So anyway, cost is the biggest thing here. So we like technology. Technology is our best friend and also our biggest enemy when it comes to this, because people don't like changes, but of course this is essential. Computerized physician order entry, you guys familiar with that term? Has anyone ever said this before? This just basically means that a provider is entering a medication order into a computer system. Pretty straightforward, right? Before that, what happened is that everyone would have to write things down on paper, which actually still happens in some areas of the country in some health systems. So Minnesota is pretty, I would say, forward-thinking in our mindset with technology and healthcare and using the two in conjunction to make things safer. And we don't have any paper charting in Minneapolis, St. Paul area anymore. There might be some rural areas that do it still, but I can't even think. A lot of them have gotten eaten up by like Illini or Fairview and different health systems, so they're all on board with, or they buy their electronic medical records from Illini or Fairview. So that's another whole conversation we're going to get into. But anyway, you might go to some place that still does paper charting or paper orders, and what that is as a provider, you write down your orders, you put it in a basket somewhere, and some poor pharmacist has to go through these handwritten orders and decipher handwriting and type it into a computer system and transcribe it that way. So this thing decreases that whole step. Now, while it makes a little bit more work on your end, the provider end, it decreases a ton of errors because there's no handwriting or transcription problems, and you're getting it directly into the computer. It still goes to a pharmacist to be checked. So once you enter an order, it will go and get verified by pharmacy. Then we can direct it where we want it to be dispensed. So maybe it's dispensed from an Omnicell, which is like a big vending machine on the floors. Or maybe it's sent to our main pharmacy. Maybe it has to go to our IV room to get made. But that way we can direct that. We can also check interactions, check dosing, see if it matches all our policies, the appropriate medication. So from your end, you just need to make sure you get the dose in. But if you enter something really weird, you might get a phone call on it or a page. Bedside barcoding is another thing that's the other side of this. So computer order entry has thought to be one of the biggest reducers in drug errors in modern medicine, basically. So that's a huge step forward. Bedside barcoding is the other one. So this is something that nurses will actually take a product, scan it before they give it to a patient. So we barcode everything. Everything comes in a little unit dose tablet. If we don't have that available, we make our own unit dose labels and put it on a product, which of course is humans doing things, so that's error prone, but none of these systems are completely fail safe, but it does happen a lot where a nurse maybe has medications that were stocked incorrectly, the pharmacy put in the wrong spot, so they pull it out, they don't really look at it because they think it was the right thing. Why wouldn't it be? They go and scan it and it gives them an error, and they say, oh, I'm actually going to look at this error instead of overriding it. And yes, sure enough, it's the wrong medication. It was funny when you first went live, you get a lot of calls, be like, I'm scanning this, and it's saying it's the wrong thing. It's like, well, what are you holding? Oh, yeah, it's not the right medication. Yeah, well, there you go. So it turns out it does work, but it is a big pain, I think. However, again, 78% of ADEs are related to system failures based on some studies that have been done. So it's thought that these things take a huge chunk of that out of play. Now with human error, there's certain things you're never going to get around. And we talk about the rule of percentages. If we're 99.9% accurate, but we're dispensing 10,000 things a day, there's going to be errors. It's unavoidable. Humans aren't perfect. Computers aren't perfect either. So we can do our best with all these things. Have you guys ever heard of like the Swiss cheese model where it hits enough holes and everything lines up where it eventually gets to a patient? It does happen every once in a while. Some people are looking really confused. Think about it like 4 squares all lined up and all the holes of the Swiss cheese align together, and your error gets through, each one being a barrier to getting the error to the patient. So you have all these double checks in place. So you have a technician checking, you have a pharmacist checking, you have a nurse checking, you have a barcode checking system, you have the provider entering it correctly from the beginning. So you have all these things, but you can move through all those pathways and still have an error. It is possible. But the goal is to make that very hard to do, and that's what all these systems are in place. Let's see, do I have any other thing else on this? So common detection methods, incident reports. So we have a thing called PVSR, which is patient visitor safety. So somebody has some sort of a safety incident, and it gets discovered by an employee. You're supposed to write it up. This is a cumbersome method, and most people don't do it unless it's something really big, which is okay because we want to catch those. But what it doesn't catch are near misses or are things that are really close to getting. So if maybe we're getting 100 instances a day where we're almost giving the wrong med to somebody, but it's getting caught at the last second, that might not get reported because what nurse or pharmacist or physician or provider, whoever, has time to document 100 specific instances. No one does that because they just don't have time. So like when I'm checking things that are going up, like in our central pharmacy, to be stocked on the floors, and I catch 5 mistakes, I'm not going to go document those because I just don't have time. That's the truth of it. Chart review. You can go and manually review charts and find things. So like let's say I'm reviewing my patients for the day, and I see, well, this patient looks like they got a double dose of something this morning. Like the overnight nurse gave it, and the morning nurse gave it too. That's what happened there. So that's, of course, you're going to stumble on that by chance. You can't rely on a system to tell you that. And then there's direct observation. Maybe you actually saw the event actually occurring. There are some cooler real-time strategies like in trigger tool integration. That's sort of the future. And what that means, and this is all I'll say about this, is that like let's say you have a lab value that comes back. You might get a real-time alert saying, hey, my patient's potassium dropped overnight and their morning potassium's super low. And maybe they're on like a high-dose insulin infusion or something like that. Or maybe their insulin's running at a higher rate than it was because of the endo tool. They're getting replaced appropriately. Or maybe they missed a replacement or missed a dose or something. So who knows? But it would give you some sort of an alert saying, hey, this lab's back now, you need to do something. And we have some fail-safes like that in place, but they haven't been fleshed out fully. So I think that's the future. But the problem is, you always run into this with electronic systems, is alert fatigue. And so how many alerts can we give somebody before people just start ignoring every alert? And we're already seeing that with the nurses in the barcoding system. Scan it, they get the error, they're like, oh yeah, this thing never scans right. And our technicians do that too. They should be scanning everything before it leaves the pharmacy to confirm that it's the right thing in the computer. So we not only have a pharmacist and a tech check everything, we also scan it in the computer system. And sometimes the techs will bypass that because they're like, well, that's just some barcoding issue. Or no, this is right, I know it's right. It's like, well, actually it's not. So there's, again, a lot of things that we can improve upon, but I think we're moving into more some of the real-time strategies. But it's very difficult. Because if you actually think about it, you can't ever get anything in real time if you're relying on lab values. Labs take a couple hours to come back, and who knows when that person's potassium started dropping maybe it was the night before. So real time is a very relative term. So just some advice I have for you guys. Be comfortable with an EMR. If you're working in the cities, you're going to be really familiar with Epic very quickly if you haven't used it already. And it's something that every system in the Twin Cities uses Epic, some Epic module, and they're all pretty similar. Every site has slightly different brands of it, or slightly different builds of it. Like Hennepin County is a testing site for Epic, for example, so they're going to have more new features that Alina won't have access to. Children's, if you do peds, they use Cerner, which is sort of like an Epic competitor. It's Epic's biggest competitor, and it's very similar, just slightly different. So anyway, just be comfortable with it, know what you can use it for, know how to use it. Err on the side of safety. I always think it's fine if a provider's like, I'm having a lot of trouble entering this, can you run me through this? And we'll talk about it over the phone together. I'd much rather do that than get a really odd order into my queue and have to call you or track you down. Because then I feel like I'm bugging you, and I'm sure you'd prefer to get it right the first time, right? So use the tools available. You can check labs. A lot of med order systems will pull in labs. Like if you're ordering something, it might tell you, hey, this person's creatinine is really high. So there's some nice tools that do that, and it also shows that on my end too when I check the med. How to assess drug interactions. There's databases to do that, but the computer systems are also built to flag you if you put in something with a really significant drug interaction. How to identify allergies, and this is a question I get a ton where you'll see a surface level allergy list that'll say, hey, they're allergic to morphine. So I'll get a call and be like, hey, this patient's allergic to morphine. What am I supposed to do? Well, their morphine allergy is nausea. That's not really an allergy. We can get around that. Let's figure something out. So just looking at what is the actual allergy. Is it something you have enough appetite for risk to go around in that case? Making extra work for people. So this is a plug for my crew, my pharmacy profession. I think that it's just important to look at what's ordered. You'd be surprised at how many people will just go and order things, and then it's already active orders for the same medication, or they order another pain med on top of a current pain med, and it's like, well, do you want the new one? Do you want to delete the old one? Just make sure you're double checking that and removing things you don't want and keeping the ones you do. And then in your instructions, just clarity is always preferred. So more clarity is better than none. There's always instructions. You can always free text stuff in. So if you want to leave a little message like, our system, for example, won't let providers put in certain instructions if it's really odd. So like if you wanted to dose something every other Wednesday, like something really weird like that, you'd have to manually type that in, but just make sure you're clarifying that. You can do like a not available, and then you can manually write your rationale. Yeah.
how does it work? Because I know like a lot of providers will order like every scenario that they can think of. Like, well, what if my patient has nausea? What if they have a headache? What if they have this? Do you have to like go through all that stuff and like send it up there, or most of that stuff?
So most of it's stocked. So we use this OmniCell system, which is again these vending machine things. So like every standard admission order set's probably going to have something for nausea, basic pain meds like Tylenol and ibuprofen on it. Might have narcotics depending if it's like a post-op order set, but you can always add those things manually if you needed to. If you're admitting somebody for like a stroke, it's going to have blood pressure medication and those types of things on it too. So there's a number of order sets that are pre-built to help you with that. Most of that stuff we have stocked throughout the hospital, so we don't have to send a lot of things. We just have to make sure our machines are staying stocked.
Okay, so that doesn't make like a lot of extra work.
It's not a lot of extra work for us. It's only becomes extra when it's like maybe a new admission on a, let's say we get a patient who's got a lot of psych history and a lot of psych meds, and they're on a med surg floor where we don't do a lot of psych, but they have some sort of medical reason to be there. We might have to add a bunch of psych meds to that unit's machine so that the nurse can access it for like the week they're going to be there. So we stock things on demand that way. Other hospitals will stock things on a daily basis, so they'll send up individual doses. We prefer to do it proactively and then destock as we need. So let's say person discharges after 2 days, we can go take all those meds back out and reuse them somewhere else. So that's just our strategy. But yeah, basically, access is all about, I think the only reason you need to be concerned about access if you're ordering something odd, if it's like a newer brand name product, maybe think about whether we might have that or not, or if it's a really odd thing. Sometimes we have to have like a specialty. One of the biggest things I see people coming on are like the MS drugs, which I didn't really talk about. They're super expensive. Only specialty pharmacies can dispense them, and we never stock them. We don't even order them in because they're insanely costly. So in that case, we have patients bringing their home supply. So if you have somebody on a really odd medication, you could tell them, they might need you to bring this in. But nurses and we get pretty involved in the admission process as pharmacists now with our like medication reconciliation stuff. So we can troubleshoot some of that too. And you can always, of course, call if you have any questions on that stuff. So that's where I was getting at with that off formulary comment. So hospitals have specific formularies, and we usually have a way that it'll trigger you. If you order something off formulary, it'll say, hey, this is on formulary, but this is. Are you okay with this? Generally, please say yes. If you have a really good reason not to, it's okay, but you might want to clarify that specifically, because we might not be able to get the non-formulary medication in very easily. E-prescribing, so that's more inpatient, outpatient. E-prescribing is pretty widely spread now, and we can actually e-prescribe C2s, which is new. Couldn't do that for a really long time, and I think there's restrictions on how you can do it. But I know, like, my wife just had a small surgery, and she got her post-op Percocet e-prescribed, so to like Cremolina to I think a CVS or something. So they can do it now, but I can't remember what the restrictions are. You have to be set up as a provider in a specific system, I think, to do it. But it is a really nice system now. Before, you always had to handwrite those prescriptions. You may not have access to all the great EMR features, and that's where you're going to come into a place that's still on paper charting, which, again, those are dwindling, but you might counter them depending on where you end up practicing. And just make sure you're being more careful with your manual checking, asking about medications and allergies because it might not be updated in the chart, and don't assume pharmacy will don't assume the pharmacies and the RX2 will actually provide the counseling. I think this is a big thing that legally, yes, pharmacists are supposed to do this, but if there's really important counseling points you don't want the patient to miss, do them yourself. I think it's important. You want to make sure the patient understands the medication they're on. And if they hear it twice, that's probably better, right? Cost, again, we've talked about cost a lot, and just if it's not covered by insurance, you'll get a phone call on it. All right. I want to talk about transitions of care quickly, because this is a pretty big changing area in hospital care, I think, in general, and how we're dealing with transitions and avoiding the trouble points in transitions. So transitions are really problematic. Anytime someone moves from one area of healthcare to another, there's always misinformation. Something always gets lost, something gets messed up. And it's really challenging to get a streamlined process, but we do the best we can. So the biggest things that I work with are admitting and discharging from the hospital, but really anytime you could go from hospital to assisted living to home, think of those kind of as transitions. Clinic to clinic transfer, if somebody was moving from a clinic that closed and you're picking up new business, that could certainly be an issue. Their records might be really old. They might have an H&P med list that hasn't been updated in 3 years because they didn't keep their records up to date. you'd be shocked at what kind of people get sent in with H&Ps from clinics for surgery that are terribly wrong and inaccurate. It's really almost scary. Like you're wondering who even took this and who wrote this down. So anyway, why is this important? Because it's a huge potential for error. If you send a patient in from your clinic for surgery and their med list is wrong and those meds get reordered and given, that's a potential risk for drug events or adverse drug events right there. So how do we prevent this loss in translation? Well, we consider a number of things. Medication reconciliation and doing appropriate medication history on admission is key to some of this. Discharge counseling is something that is important too. The way our system works is we have pharmacists do the med intakes for patients, so we do all the history in the beginning, and then discharge counseling is done by nurses. We assess the patient's medication needs, so understanding the regimen, access to medications, and affordability is really important. I've talked about that a number of times, so nothing new there. And also, interestingly enough, if you provide patients with medications when they leave the hospital, they're 30 to 40% more likely, or they're much more likely to actually take them and fill them. If you give them a stack of prescriptions and send them home, or even if you e-prescribe them, they can be like 30 to 40% will never even fill their medications if you give them actual prescriptions. It's kind of interesting. They just take them and, I don't know, they leave them at home or decide they don't need them, and they readmit to the hospital 3 weeks later. So discharge pharmacies, even if your patient's not going to continue filling there, if they live in rural Minnesota and you're filling in Minneapolis or whatever, still worth just giving it so they have a month's supply in hand. Gives them time to be able to get their home pharmacy set up, get refills sent to their wherever they're going to fill them long term. So it just helps the patient out a little bit more that way. Okay, MedRec, I'm not going to talk too much about the details of this because this is a big pharmacy initiative that's kind of going on nationwide, and especially in Minnesota. But the point of this is that when you get admitted to the hospital, there's kind of 3 steps. So first of all, you're going to collect a basic medication list from a patient. You're going to ensure that those medications and doses are appropriate, and then you're going to order them. So those are the 3 steps. When we get involved with this, the idea is that we get points 1 and 2 done before point 3 happens, which makes sense. But oftentimes point 3 just happens, and then we have to do point 1 and 2 retrospectively, which is really frustrating. So a great example would be people coming from surgery and getting admitted to the hospital. That's probably the biggest area where we've been working recently, is these surgical people will come in. They weren't getting any type of medication history done that was very effective, and then they were going up to the floor, getting all their home meds reordered, and half of the time we were spending changing doses, calling providers, trying to page surgeons at night is impossible. If you guys are going to be surgical PAs, you're going to bear the brunt of this. So this is an initiative we've taken. So we go into pre-op now as pharmacists. We actually talk to patients before they go into surgery or meet with the nurse, get their med list updated, and then we send them through if they're going to be admitted to the hospital. It takes a lot of the clarification stuff out in the beginning. That way, when you order the medications post-surgery, you're all good to go on that end. It's been, I think, a huge game changer for us, and it's been something we've been pushing a lot more towards lately, and we've actually hired a lot of new pharmacists to do this type of work. So that's just a way that we've involved ourselves in transitions, but certainly, there's a lot of areas for providers to get involved with this too. This is just some data that I'm not going to go through that says pharmacists are great, and we did a lot of really good job at our hospital. Pat on the back. That's old data, but we just to point out, we were doing like 30 to 40% of all hospital admissions as far as MedRec goes, and Abbott admits probably 80 to 100 patients a day. And now we do almost 95%. So we've seen a huge uptick in that, and we just reprioritized it. So the nice thing is if you work at Abbott or any Atlanta hospital, we're all pretty much doing the same thing. You know that the MedRec's getting done by a pharmacist. And I think everyone universally agrees that pharmacists do the best job at this. And I'm not trying to toot my own horn here, but I've had a number of providers just come up and be like, can you just do this because you're better at it than I am? And I admit that. It's like, no, thank you. And it's kind of grunt work too, so it's like a little bit of like, hey, can you do this like stuff I don't want to do? But we'll do it because we want to make sure the patient's experience is best and safe for everyone. So anyway, the point is that you might not always have that. You might not have a 95% pharmacy coverage. So you might have to do this yourself, or you might have to rely on your nurses to do it. And just know that stuff gets missed. Patients don't always tell the truth to people. You might get different versions of their truth, or alternative facts, shall we say, from different people talking to different patients or different. Like I've had providers come up to me and be like, I read your note and he didn't tell me any of that. I'm like, well, I don't know what to say. That's what he told me. So it's like, they might be more open to a nurse than a provider. They might be more open to the provider than the nurse. Just depends. Too many cooks in the kitchen. I've seen like times when 3 nurses have tried to do an admission home med list, and they just totally mucked it up. So sometimes when one person does it, if you ever have questions, talk to the person. Talk to your nurse and make sure that they know who did it, who they can talk to, or if there's clarifications needed, how to get that done. And if nothing else, ask the patient. Call their home pharmacy. There's a number of electronic tools we have too that can do that. Like our electronic medical system actually pulls in pharmacy dispenses and insurance claims and shows you what people have filled recently. Super helpful tool, especially for adherence. So anyway, there's a ton of resources. We talked about the PMP with controlled substances. If you're prescribing controlled substances, get access to that. And not only can that help you see if somebody is doctor shopping, it can help you see if they're filling narcotics on a regular basis. So if you're doing chronic pain, when's the last time they got their oxycodone? Patient and family, discharge summaries, home pharmacies, those types of things. Patients who discharge from a skilled nursing facility will usually have a very specific laid out medication administration record that has doses documented on it. That's, of course, very helpful, too, for people coming into the hospital. Anyway, this is important, and I just want to highlight that. That's really the point of this. So when it comes to patient care, it's really easy to mess things up if you don't do it right from the beginning. That's why I think this is important to address right away, and then you can let your stay happen. You can take care of the patient as you need, and then you don't really have to worry about the home meds because they're taken care of right off the bat. I think people think of it as a clerical process, and that's where it gets shuffled to the side. So we talked about hospital versus clinic. In the clinic, current detailed medication lists is essential. I think that's really important, and to go through it with them. Whether it's you or a nurse going through it with them and updating it, it's really important. And if you make a change, please actually update their list and the medical record. I think there's so many times that patients will come in with like scribbled out notes, and it's like, it just looks really bad. And they're like, well, I can't remember which one was which, and they just changed one of my doses and I didn't write it down. So, making sure the patient has all the tools they need to succeed. And again, ultimately, my point here is that this is important. I'll say that one more time, and then it falls on your shoulders. So you're the ones ordering the medication. So I can do all my work, and the nurse can do all their work, and we can try and get the list up to date. But you need to be confident in the accuracy as well. So you can trust your colleagues for sure. But if no one's doing this or no one's talking to the patient before you're ordering, that's a big risk you're taking, just ordering a home med list that you have no idea if it's right or not. So just keep that in mind. And yes, we already talked about this. So. And yeah. Discharge, set your patient up for success. Review the med list of the patient. You don't have to go through the whole thing if the patient's on 30 or 40 meds, but I would say just if you're changing things, make sure you talk to them about them. Talk about the big changes, address those things with them. Make sure they understand that. Follow-up's really important too, of course, so making sure they have that. If you don't do those things, you get a readmission. Then you get more healthcare costs, your hospital loses money. It's not good for anybody. So again, this is a huge correctable system, or correctable area within our health system that is, I think, been failing over the last several years that we're slowly starting to correct. It's a good thing. It's definitely a process change and a mindset change. So. With respect to the test and this type of information, I'm actually going to give a short answer question that's worth 5 points. And I'm going to ask you just to kind of give me a scenario on what your ideal practice would be and how you might incorporate good transitions of care practice into that. So it could be talking about going over meds with patients, it could be talking about medication reconciliation, it could be talking about discharge counseling in a hospital setting, whatever you want to do. I just want something insightful. I don't want you to regurgitate what I said. I want to say, it's really important. Chad really likes this. This is great. That won't get you all 5 points. But I don't think I've ever taken a point off on somebody. So, again, the test has a question worded very specifically, so it should be pretty clear. But anyway, just to give you a heads up that that's going to be on the exam. So. Also, with the exam, has it been communicated to you? It's not on Monday. You guys have the schedule. I'm not proctoring it, so anyway, that's that. I just wanted to say thank you guys. I think you guys are number 4, right? I'm losing count now, so yeah, I think you're 4. So I've done this 4 times. I've changed it every time. So it's like every year I'm like, oh, this will be such smooth sailing. It's not that it's not. It's just that every time you guys, each class is challenging as far as saying like, hey, let's do this differently. And so like with electronic stuff, I think that was a good step forward. And I'm glad you guys brought that to my attention because it works for me. So anyway, thank you. Feedback is great. I like to hear from students when they're out on rotations. Occasionally I get questions about things or follow-up things, or hey, I'm doing a psych rotation and they're using this drug a lot. Do you know anything about it? Or
I was taking my certification exam and this question came up, something like that. That's actually never happened, so maybe my stuff is good. I don't know. But anyway, feedback's good. If you want to give me feedback, that's fine, for sure. So you can do that on the email, or you can do it out in practice or in rotation. Anyway, thanks, guys.